This is a 53-year-old male with a history of hypertension and end-stage renal disease on peritoneal dialysis who presented to an outside hospital after experiencing severe chest pain and right lower extremity weakness and paresthesias. Circulatory was activated and CT was negative for any acute intracranial processes. Follow-up CTA showed an acute type 1 aortic dissection with total occlusion of the right external iliac artery and distal reconstitution. He was subsequently transferred to our Center for Surgical Management. The patient was taken directly to the operating room. Midline sternotomy was performed. The innominate vein was isolated and encircled with an umbilical tape. The innominate artery was isolated and encircled with a vessel loop. The left common carotid was isolated and encircled with a vessel loop. A small opening was created in the pericardium to allow for controlled drainage of the pericardial effusion. Of note, transesophageal echo showed trace central AI. Systemic heparin was administered for cardiopulmonary bypass. The distal ascending aorta was accessed with a needle and Benson wire under transesophageal echo guidance and directed into the true lumen. The right atrium was cannulated with a multi-stage venous cannula. A retrograde cardioplegia catheter was inserted and cardiopulmonary bypass was initiated. A LV vent was inserted. The right femoral arterial line pressure did not improve with true lumen perfusion. Thus, this was upsized to a 6 French sheath for perfusion of the right leg using a branch off of the ACP line. The patient was cooled to 24 degrees centigrade. The aorta was cross-clamped while administering retrograde cardioplegia. The aorta was transected. Direct osteocardioplegia was administered down the left and right coronary arteries. Plegitive fluoroproline sutures were used to resuspend the commissures. The root was further dissected circumferentially. The aorta was further transected down to the level of the sinotubular junction. There was extension of the dissection to all 3 sinuses without involvement of the coronary ostia. The root tissue quality was appropriate. The aortic valve was tri-leaflet. The leaflets appeared grossly normal without significant thickening or calcification. There was good coaptation suggesting a feasible repair with valve resuspension. A felt strip was cut to be inserted between the layers of the dissected sinuses and secured at the sinotubular junction level with a running 5-O-proline suture in 2 layers. The sinotubular junction was sized and measured approximately 31 millimeters. After reaching 24 degrees centigrade and completing the head vessel dissection, flow from cardiopulmonary bypass was stopped for circulatory arrest. The aortic cross-clamp was released and the aorta was excised from the ascending aorta to zone 2 between the left common carotid and the left subclavian arteries. The innominate and left common carotid arteries were cut as an island. Balloon inflatable retrograde cardioplegia catheters were inserted into the left common carotid and innominate arteries. The balloons were inflated and the vessel loops were snared. Bilateral selective antegrade cerebral perfusion was initiated and maintained at 10 mm per kg per minute. The left subclavian artery was clamped. There was a large tear noted in the base of the left subclavian artery with significant back bleeding from the false lumen. Given this and the right lower extremity malperfusion, decision was made to perform a total arch replacement with a frozen elephant trunk. The base of the left subclavian artery was oversewed with multiple plegitive fluoroproline sutures. Plegitive fluoroproline sutures were used to tack down the intima and to use as a handle for the distal cut end of the aorta. A 30 to 34 millimeter by 10 centimeter ThoraFlex Hybrid plexus graft was deployed in the true lumen of the descending thoracic aorta. The stent graft was stretched with a Surratt clamp. The distal cut end of the aorta was anastomosed to the sewing collar of the ThoraFlex Hybrid graft with a running fluoroproline suture while incorporating a felt strip external to the aorta. A Foley catheter was inserted into the graft and the balloon was inflated to reduce the back bleeding from the graft. After completing the distal anastomosis, the 10 millimeter anaflow arm of the graft was connected to the arterial tubing. Branches for the head vessels were clamped. The proximal end of the graft was cross-clamped after careful de-airing, and flows were slowly brought up to full flows. The distal anastomosis was reinforced with multiple pledgative fluoroproline sutures, as achieving hemostasis at this point is crucial. Of note, the right femoral arterial pressure became equal with the left, and thus the perfusion through the 6 French sheath in the right groin was disconnected from the ACP line. The 10 millimeter side arm of the graft was clamped and trimmed. This was anastomosed to the left subclavian artery with a running 5-0 proline suture. The anastomosis was de-aired as the clamps were released. The patient was rewarmed at this point. The cross clamp was moved to between the first and second branch, and the proximal aspect of the graft was trimmed. The proximal anastomosis was completed with a running 4-0 proline suture incorporating a strip of felt external to the proximal aorta. The valve resuspension sutures were brought through the strip of felt and tied down along the way. The heart and the aorta were de-aired through an aortic root vent. And the cross clamp was released. Next, the common carotid and the innominate arteries were separated. 8 millimeter branch of the graft was clamped and trimmed. This was anastomosed to the left common carotid artery with a running 6-0 proline suture. The anastomosis was de-aired as the clamps were released. At this point, the first 12 millimeter sidearm of the graft was trimmed and anastomosed to the innominate artery using a running 5-0 proline suture. The last head vessel anastomosis was de-aired as the clamps were released. Retrograde cardioplegia catheter was removed. Bipolar pacing wires were placed on the inferior aspect of the heart. The LV vent was removed, and the root vent was removed. At 36.5 Celsius, the patient was weaned from cardiopulmonary bypass without difficulty. The venous cannula was removed. TEE showed no AI. After transfusing volume from the cardiopulmonary bypass machine, the 10 millimeter antiflow sidearm was tied off and trimmed. After correction of coagulopathy and multiple rounds of hemostasis, chest tubes were placed and the chest was closed in standard fashion. The patient had an uncomplicated post-operative course and was discharged home on day 11. CT scan prior to discharge showed patent arch vessels and residual false lumen flow distal to the stent graft, with all visceral vessels except the left renal artery coming off the true lumen and restored flow to the right lower extremity. In conclusion, this case highlights the utility of arch replacement with frozen elephant trunk in management of DeBakey type 1 aortic dissections.